to join you guys for Mental Health Week. So that's been exciting to me. I think that we talked a little bit about a similar subject last year. Um, really glad for everybody who's tuning in and joining these lecture series that Hanun University is putting on. I think they have a lot of dedication to just providing free and open source materials like this to people to just advance education and public knowledge, especially around some of these subjects that, in East Africa, I think maybe we don't talk about enough in the mental health and the addiction realm. Um, I see some friendly names in the audience. I see Ibrahim Warsami, Dr. Huda, Khalid Gedi, a few others. Shout out to you guys, some good friends that I've had here in Somaliland that make the place special. Um, So, as you guys heard, I trained first in internal medicine in America, in Minneapolis. And when I was in my residency in internal medicine, I started in 2020, and everybody remembers that time as COVID, right? And I did, for sure, I did a lot of critical care, saw a lot of very sick COVID patients, spent a lot of time in the ICU. But what was even more notable to me in 2020 was the amount of overdose deaths that I saw. Um, 2020 was the year that the fentanyl epidemic in the USA peaked. It was the first year that we had over 100,000 people dead of overdose in that single year. And most of them were young in their 20s, 30s, teens. And in the hospital where I worked in Minneapolis, I saw a lot of Somali patients. And I saw that addiction and overdose was really, really hitting the Somali community very hard. They were devastated. And I lived in the Somali community at that time. The apartment where I lived happened to be in the heart of the Somali neighborhood of Minneapolis because it was within easy walking distance to work. And so it was around that time that I really started to get involved in addiction care and addiction recovery, specifically in the Somali community. So after I finished my internal medicine residency, I went back to the University of Minnesota and I completed a fellowship or subspecialty training in addiction medicine. And all of my work through that time was really focused around the Somali community in Minneapolis. I stayed on at the University of Minnesota as an assistant professor. But in about 2024, I got the opportunity. Some mutual friends connected me here via the Horn Partnership Network that they were looking for somebody in Gabile to help with psychiatric care and in particular addiction care, with the focus being on Khat addiction. And so I moved to Somaliland in January of 2025 with my wife and three little kiddos. And I've been here ever since in Somaliland, providing internal medicine care, seeing complex cases, and then providing help at the Gabile Mental Health Hospital as essentially a psychiatrist, but then also doing a lot of research on cot addiction and related topics in Somaliland. The first of a few publications are now nearing completion, and we'll be able to be starting to contribute to the addiction medicine literature from Gabile, hopefully within the next few months. So that's really exciting. In my presentation today, I'm going to talk a little bit about hot research in Somaliland, um, what we know and future perspectives. The goal will not be just talking about Somaliland in particular, and if we did, the research would be very limited. Khat is a under-researched field. There's large gaps in the literature, and as you guys know, even doing research in Somaliland can be very difficult just with our level of resources and organization and training that we have in the country. So my goal is to introduce you guys to Khat research, some of the things we know, some of the things that we don't know. And then I want to have quite a bit of time for dialogue at the end just to ask questions. And maybe I won't have answers to all of the questions, but I think that within the audience. We're going to have some really good questions and some really good answers, even coming from the audience. So my goal is to take maybe an hour talking. We'll see, maybe less, and then use the rest of the time to just have a dialogue and talk about what questions you guys do have. I don't have the chat up right now. I might wait till the end to address any questions that come up from the audience, since I think that we'll have plenty of time. So if you guys want to type things into the chat, I won't see them in real time, but we can come back to them at the end of the talk. So I think what's really important from the start is to establish what we're talking about when we're talking about addiction. And there are some terms that are thrown around in sort of the psychology or the psychiatry literature, or even in just in the lay press, where people, you know, might talk about substance use disorders. They might use the word addiction. You might hear people talk about dependence. And so, what I want to do quick is provide you guys definitions so you know what I mean when I am talking about addiction. And the first is dependence. So, dependence is a physical quality, it's tolerance and withdrawal. So, for example, uh, if you are the kind of person who drinks coffee every day or tea, somehow you need to have some caffeine every single day. If you miss a day of caffeine, you might get headaches, you might feel kind of sleepy, maybe extra irritable. And what you're feeling is caffeine withdrawal. So that would mean that you have physical dependence to caffeine. Unfortunately, in the lay press, physical dependence oftentimes is seen to be directly equal to addiction, but this isn't true at all. Physical dependence is not equal to addiction. Tolerance and withdrawal are criteria for addiction, but in and of themselves, they do not uh, define addiction. Another good example is SSRIs. I know many of you guys are psychologists and psychiatrists in the audience. SSRIs have clear discontinuation syndromes. Discontinuation syndromes are withdrawal. Would that mean that anybody who's taking an SSRI is addicted to an SSRI? Of course not. That would be crazy. So, physical dependence alone, even though it can be part of the addiction phenotype, it is not equal to addiction. The medical term that we use to describe the idea of addiction is a substance use disorder. This is a diagnosis that comes from the DSM-5. It has 11 different criteria. I'll walk you through those 11 different criteria real quickly so we can be all on the same page. But substance use disorder, even that term, is not exactly analogous to the idea of addiction. Substance use disorder might correlate with addiction, but the trouble is that there's no real standard addiction definition for addiction itself. These are the criteria for a substance use disorder. If you look through, there's 11 of them, and they fall into four domains: impaired control, the social impairment, risky use, and then tolerance and withdrawal. Um, Social impairment is things like, you're not able to work because you're spending all of your time chewing chat, and therefore your family is suffering because you are not making money, or you are getting into arguments with family members about your Khat use. Impaired control is more like binge using or excessive cravings, or maybe spending, hours of time chewing chat. Or when somebody really wants to cut back or stop chewing but can't, that falls into the category of impaired control. And then risky use is going to be like when you are having a physical or a physical problem because of chat use, and it's still not enough to get you to stop. I'll give you an example. I have a couple patients who have had severe liver issues because of chat. and they cannot stop using Chat. They continue to come to the hospital with worsening liver problems. That would fall into the category of risky use. And the last two are tolerance and withdrawal, which are things that we see with Chat, especially withdrawal. And we can talk about that a little bit more later. When you have just a few of these, it's considered mild. When you have more around five, 4 or 5, it's considered moderate. And if you have 6+, it's considered to be severe. So that's the term substance use disorder, and that comes from the DSM-5. And I typically refer to substance use disorders because I think that it's more precise. Uh, we have these categories, it's more clinical, it's more relevant, people understand what I'm saying. Because here's the problem with the word addiction. Here, these are 3 different definitions of addiction that come from the main governing bodies for addiction medicine in the United States. So the American Society of Addiction Medicine, SAMHSA, the Substance Abuse and Mental Health Services Administration, and then the National Institute of Drug Abuse, the NIDA. They each have, as you can see, completely different definitions of addiction, but they have some things in common, and I've color coded those so you guys can get a sense of what sort of the core definition of addiction is. It's a chronic medical disease that somehow involves the brain or changes in the brain, and it's characterized by continued or compulsive use despite harmful consequences. So if you really wanted to say, like, what is the definition of addiction, we'd say it's a chronic brain problem that involves continued use despite harmful consequences, right? But because that doesn't really have the same sort of clinical criteria, that doesn't have the same precision, that's where in medicine, oftentimes we use the idea of a substance use disorder to talk about the idea of addiction. And there's sort of an idea in literature that once you kind of meet the criteria of moderate or severe addiction, where you're meeting basically around half of those criteria, those bullet points that I showed during the previous slide, that's where you really have the idea of addiction. But there's no hard and fast rule. Before talking about Khat, I want to take 1 second to just have you guys think about this question. What substances are the main drivers of morbidity and mortality worldwide? Okay. Maybe think about the top 1 or 2. Like when you guys have heard all about fentanyl in the USA, I was just talking about 100,000 overdoses in 1 year back in 2020. Cocaine, methamphetamine's a big problem, especially co-use of methamphetamine with fentanyl. Alcohol, tobacco. What one do you guys think is the biggest problem? So globally, about 20% of the population reports heavy episodic alcohol use in the last 30 days. It's like 1 in 5 people. 15% of the world's population smokes tobacco each day, but 80% of that is in the low and middle income countries like Somaliland. And only 6% of people used illicit drugs in the last year. That means that the rate of alcohol use disorder is 4 times more than the combined rate of illicit drug use altogether. And the WHO tells us that tobacco use is actually the number 1 preventable cause of morbidity and mortality in the world. Maybe let's look at it this way. So this chart shows the DALYs, the DALYs are disability adjusted life years by each substance. Okay, and this is from data from the Lancet. And the blue is going to be disability adjusted life years. So basically, morbidity and mortality from tobacco. The orange is alcohol, and the green is everything else. And that includes Khat. And so I think that it's important to start by talking about this slide because Khat, even though it's a huge a very important topic in the Horn of Africa, in Somaliland. It's still not the main thing that's driving mortality in our community. Tobacco is still the main thing that's driving mortality in our community. If you can address tobacco use, you can address Khat use. And if you can address Khat use, you can address tobacco use. I'll show you guys in a few slides. There's tons of data out there that supports the idea that those who use Khat smoke more cigarettes. The more Khat you use, the more tobacco you use. And maybe vice versa is true. The more tobacco you use, the more Khat you use. And what's important about this is we can address Khat addiction, and that's going to have a real detectable effect on our community. But anytime that we're talking about Khat or researching Khat, we should also be looking at tobacco, because tobacco use is something that drives morbidity and mortality in this world. So if we really want to help our community live longer and live better, we really have to be addressing tobacco use at the same time that we're addressing other substances. And we know from the addiction literature that when you treat tobacco use at the same time as other addictions, they both get better. This is something that's been played out multiple times. If you help somebody who has an alcohol use disorder quit smoking tobacco, they will actually have a more robust recovery from alcohol use disorder. So getting back to Khat, I think most people on this call have an idea of what Khat is. So I'll give a short introduction for people who maybe are watching from other countries. Khat is going to be the name of sort of the leaves and the soft sort of twigs of a plant called Khatha edulis, which is a shrub that grows in places like Ethiopia and Yemen, some places in Somalia and Somaliland. It's a common plant here in the Horn of Africa, and in particular the southern part of the Arabian Peninsula. And depending on the year, it's actually been, and kind of the way that you measure, it's been Ethiopia's #2 to #4 export commodity. The history of Khat is really interesting. The first recorded written use of Khat goes back to the 13th century, but oral traditions trace it back to about the year 800. In the USA, cathinone, which is the active molecule in Khat, is Schedule 1. And so, sort of by extension, Khat, the plant, is also considered Schedule 1. So this would put it in a similar category as things like methamphetamine. But it's a little bit more gray because in the scheduling in the USA says that cathinone alone, or cathinone is specifically called out as being Schedule 1. So it's a little bit more of an extrapolation when people get into legal problems because of Khat use. In the Horn of Africa, in Yemen, where it's used very commonly, Khat is legal. Now, it's always really interesting to me because I know that Khat is legal in most of the Horn of Africa and in Yemen, but in other countries, even in the Arabian Peninsula, I'm thinking about Saudi Arabia in particular, Khat is illegal. And so it's been kind of an interesting source of debate, because how much of Khat regulation is going to be coming from social ideas versus political ideas versus even religious ideas, because Khat is primarily used in areas of the world that are Islamic. And so it's a very interesting thing to track the legality of Khat across the Horn of Africa and the Arabian Peninsula. In most of Europe, Khat is illegal. This has been a dynamic situation in the last 20 years. And I think that we might continue to see more change. What's interesting is the WHO, the World Health Organization, defines Khat as being not seriously addictive, but they are very interested in researching and understanding this better. And I think it'll be an interesting point of conversation to see what you guys think on this call. Here's some pictures of people using Khat or purchasing Khat. We have a Makahi there on the bottom left, a very familiar site for those of us here in Somaliland. And the route of administration of Khat is interesting because it is absorbed transmucosally. So it's chewed up, put in the cheek, and then it is absorbed across the oral mucosa over time. Khat chewing sessions usually last hours on end, and historically they were more of a group tradition, maybe uh, elders or more prominent men in the community getting together in evening, maybe on a Thursday night or a Friday, having sessions where they would chew chat, discuss politics. But I think that we've seen a change in sort of um, the patterns of khat use over the last 10 or 20 years in Somaliland in particular. We're now, seeing people out of Makahi purchasing chat in the morning, consuming chat in the morning, or even people who are chewing chat, consuming chat alone and outside of sort of the normal, more traditional social context is becoming more and more common. And in that, there's probably some issues. The Horn of Africa isn't the only place that has a large amount of cot use. I think that most of the statistics that have looked at Yemen actually show even higher rates of cot use in Yemen compared to the Horn of Africa. So, for example, 90% of men in Yemen are spending 4 to 6 hours per day chewing chat and spending about half of their household income on chat, which is just insane. I mean, that's probably all of their discretional income as well. Um, 15% to 20% of children, yes, less than 12. Um, Very concerning trend to see cot use in children, especially because the vast majority of people who develop an addiction, their first use of that substance is around 12 to 15 years old. In East Africa, there's been a lot of studies that have shown a lot of different numbers. So, for example, 10% of the population has shown dependence in East Africa, but then studies that have looked at European countries and people who chew chat there show numbers as high as 85%. 20% of Ethiopia uses chat each day. And then among Somali men, there have been a number of studies from both Somaliland as well as Somalia, and that shows that around 37 to 70% of adult Somali men are chewing chat each day. And I would say looking around in Somaliland from what I've seen, that sounds about right. Maybe even closer to 50 to 70%. Uh, there's been a number of studies that have used the DSM-5 to formally assess for cot use disorder. And what those have shown is that the minority of people who use chat meet substance use criteria, but the majority of those do have a severe cot use disorder. I've done research here in Gabile that actually affirms this idea, and we'll come back to that again in the future because it's rather interesting. So this is a quote that comes from a guy named Michael Oldenwald. He did a lot of research on Khat in Somaliland and Ethiopia and Kenya in sort of the 90s and early 2000s. And this quote I thought was really revealing because I think it captures something that we're seeing in the community and the reason why this is here as a topic during the Mental Health Week this year. So he said the traditional way of consumption was socially highly regulated. Adult males, more seldom females, would gather and chew chat together at a cot party, usually on weekends and afternoons, until the time of the evening prayer. Contrary to this formerly restricted use, current habits involve use by adolescents, chewing cot in tea shops that operate day and night, early morning use, as well as binging and speed runs that may last for more than 24 hours. And I think what's important to note is that this is something that he wrote in 2005. That's like 20 years ago now. And think how much this has changed. I would say I would hazard to guess that this is even more true now than it was in 2005. And this gets to one of the real problems in the Khat literature right now, which is that a lot of the literature around Khat that's in medicine and in science is about 20 years old. And Khat use has continued to change since then. Our people who are using Khat are younger and younger. People are using Khat more and more consistently. The distribution of cot has gotten more and more advanced. If you want to stop at a cot stand at any time of the day now, you can get relatively fresh shot that's very potent. Even if it's the morning, the night, the weekend, the weekday, you can find it. And that's something that's changed over the last 20 years. And I think the other thing to note is that even when he was writing these words, um, Somaliland, for example, was recovering from genocide. The picture on the bottom right, there was parts of Somaliland that were bombed completely flat just a few decades ago. Uh, Times have really changed. And so what we're seeing is that COT has also entered a new era that is not being well captured by the research that was done around the time of the genocide, the Civil War, and the Reconstruction era afterwards. So, what is in COT that causes the effects? The active molecule in COT is called cathinone. Cathinone is this one here in the center of the screen. If you take a look at cathinone and you compare it to this molecule to the right of it, that's amphetamine. And as you can see, cathinone and amphetamine, they're very closely related. The only difference between cathinone and amphetamine is this ketone group. Cathinone, when it is, as soon as it's picked from the tree, this ketone group starts to oxidize to a oxygen group or an alcohol, right? And this process happens spontaneously as soon as the molecule is picked, or as soon as the cot is picked. And caffeine, this molecule here, is about 10% as potent as cathinone. This is why the cot trucks drive so fast. As soon as you pick the cot off the tree, this cathinone is turning into caffeine, and every molecule of cathinone that turns into caffeine is only 10% as potent. So the longer that leaf is away from the tree, the less and less potent the cot is. The end consumer wants as potent of a product as possible. And so this is why the trucks are driving super fast, and as soon as the cot is picked, it's shoveled away and they try to bring it to the consumer as fast as possible. Is try to preserve as much cathinone in the cot plant as possible. Other similar molecules are MDMA, which is ecstasy, methamphetamine, which is a sort of a molecule that's very similar to amphetamine with one methyl group. And bupropion, which is an antidepressant that's used in psychiatry, is actually a cathinone. You can see it's a highly substituted cathinone backbone. And so we actually use cathinones to treat depression in medicine. The mechanism of action of cathinone is very similar to the mechanism of action of amphetamine, where it essentially causes higher levels of dopamine in the brain. It blocks dopamine reabsorption and also causes dopamine release in the synapse. But cathinone also has a little bit more serotoninergic properties like MDMA. It also causes, to a greater extent than amphetamine, the release of serotonin. And this is where the clinical effects of cathinone are a bit different than just those of amphetamine, where you see maybe a bit more pro-social effects, at least at first, with caffeinone. The traditional idea of people chewing chat, getting together, talking, having a period of sort of sociability and then a period of reflection. That has that clinically is a little bit more similar to the pro-social effects of MDMA, but then we see also clinically as well as in pathology that's more similar to the effects of chronic amphetamine use. And this is where we get to the idea of Khat addiction or substance-induced psychosis. So in the literature, the idea of Khat addiction is always something that's brought up with sort of trepidation or hypothetical. Um, and that's in large part because a lot of the literature is fairly old. Community level in Somaliland, what would you guys think? Would you guys think that there's such thing as Khat addiction, or do you think that this is something that's, you know, not true, or something that's maybe a uh like a fantasy, or maybe some misplaced blame? There's been a number of different studies that have looked at Khat addiction using the DSM criteria, the severity of dependence scale, and a few other validated research scales. And even though there's not an extensive body of literature, meaning dozens or hundreds of studies, the maybe 10 or 20 good studies that have looked at Khat addiction systematically using modern addiction scales like the DSM, the severity of dependence scale, have all been positive, meaning that Khat use chronically and its effects do meet criteria for addiction. And I'll share with you guys some research that I've done personally that corroborates this idea that Khat is capable of causing addiction. And what's maybe even more relevant and possibly even more concerning is that chronic Khat use seems to be highly associated with the development of psychosis or psychotic symptoms. So that's going to be things like delusions, hallucinations, paranoia, disorganization. And it's been noted for now decades that people who chew large amounts of Khat develop psychotic symptoms. One of the limitations of previous research around Khat-induced psychosis is that these areas where the research was done had large amounts of PTSD and trauma from conflict, right? Civil war, wars with other countries, just the trauma of famine and abuse, and some of the human rights violations that have occurred here in the Horn of Africa. You know, a lot of the previous research, it was hard to parse apart what the real effect of Khat psychosis was versus underlying psychiatric comorbidities. And this is a big gap in the research now, is to do research in sort of the next generation of Somalis that have grown up in a more or less stable world without, planes bombing them and severe war trauma, and say, okay, what are we seeing now? And that's what some of my research is starting to untangle. There have been a number of different medical complications that have been consistently documented with chronic Khat use. Cardiac disease like cardiomyopathy, hypertension, strokes, heart attacks, all of those things that you see with chronic stimulant use, we see with Khat. Oral cancers, as you can imagine, Khat is irritating to the oral mucosa. It can then lead to squamous cell carcinoma of the mouth and of the cheek. And I've also seen a lot higher rates of esophageal cancer here in Somaliland than I would expect, but there is not good data to corroborate any strong link between esophageal cancer and Khat use. Sexual dysfunction is a common complaint, erectile dysfunction. is a common complaint among men who use chat. Hepatotoxicity is something that's rare, but there's a number of different studies that have looked at Khat-induced hepatotoxicity, in particular acute liver failure. And anecdotally, I've seen two or three cases now of acute liver failure in the hospital in Gabile, that their main exposure has been Khat use. Interestingly, the literature that looks at hepatotoxicity and Khat use, there seems to be some concern that it's related to pesticides that are used on the Khat when it's grown, that are and maybe it's the pesticide that is causing the hepatotoxicity, but this is not something that's been settled yet. And then Khat can cause a number of pregnancy complications, things like preeclampsia, uh, uh, premature birth, low birth weight, things that you see commonly with other stimulants like amphetamines and cocaine. There is a real lack of preclinical research around Khat use. In particular, looking at the different ways that we measure addiction in lab animals. So, in lab animals, there's a few different ways to measure addiction. You can have them administer the drug to themselves and see how long they'll do it and do different tests. Or you can set up test methods where they're actually able to inject the molecule straight into their brain and see when they'll use it, how much they'll use it. And then there's a more simple method called conditioned place preference. And the only method of preclinical research on animal models of Khat addiction has been done using this idea of conditioned place preference. And the studies that have been done are positive. So meaning that Khat does show an addiction phenotype in mice. And I think that they're really interesting studies. So I just want to explain to you really quickly how these studies are done. So what's done is you take a mouse and you have it in a cage that has three separate compartments. One compartment is neutral. One compartment has one sort of visual cue. The visual cue on this side is stripes, and then the other has another visual cue like dots. And what's done is the mice are placed in one of these boxes and they go through a period where they are consistently given the drug in one of the compartments. So, for example, the way that these studies are done is that the mouse is put into, for example, the side with the dots. And then every day for multiple days, they are given an injection of Khat, the preparation from Khat. Now, over time, the mice will show that they prefer being on this side of the cage. So, for example, every day for a week, you take the mouse out of the box and you put him on this side of the cage where he gets an injection of Khat. Similarly, you put him on this side of the cage where he gets an injection of saline or some kind of neutral stimulus. And then you put the mouse in the middle and you test how much time they want to spend on the Khat side. When this is done, the mice show behaviors very similar to methamphetamine. They'll stick around on this side of the cage and try to spend as much time here as possible because they are anticipating getting the reward or the high of Khat. And there's even some more complicated neurobiology behind that. But what's interesting is that the effect of Khat compared to the effect of methamphetamine in similar studies is about 50%. So the effects don't seem to last as long on the mice or be as robust. And so this is consistent with what we know about the neurobiology of Khat and cathinone, how it works. It causes the release of dopamine, but not not to the same degree as methamphetamine. So what does all this mean at the end? Khat produces an addiction-like behavior in mice, but it is not as severe as the addiction-like behavior that we see with methamphetamine, at least in the way that we study, at least in this kind of study. It would be very interesting to have more preclinical research done on the effects of Khat because the other research that's done around Khat and Khat addiction has so many other variables with the social context and the political context of Khat use that I think it would be a huge help to the Khat literature field to have more definitive preclinical research because it moves us away from just these social and political ideas that sort of muddy the truth about Khat use. I'm going to skip this research for now, just for the sake of time. Um, Here is some highlights of some of the research that I've done at Gabile Mental Hospital. Um, so this is all sort of pre-publication. So this is information that we're going to be sharing more widely. So this hasn't gone through the process of peer review, but this is the truth as of a couple of weeks ago when I prepared the slides. Now, in our hospital, and you have to imagine this is going to be among the people who have been admitted to the mental health hospital because of Khat use. These are going to be people who maybe will be the most severe we would expect, right? Like if you're admitted to the mental hospital and you have an addiction, we would expect that the addiction would be more severe than those who are just going about their daily lives in the community, right? Um, about 87% of our males chew chat every day. So 80% of the males admitted to the psychiatric hospital are chewing chat every single day. So not just the majority, but the vast majority of the men in our mental hospitals are using chat every single day. And what's even more concerning is of those people who chew chat, 80% of them meet criteria for severe Khat use disorder. And this is actually rather remarkable because what you would expect, just like any other addiction, you would expect that the majority of people have a mild addiction, and maybe fewer than that have a moderate addiction, and then fewer still have a severe addiction. But what we've seen in the psychiatric hospital is actually the opposite, where the majority of people who use Khat have a very dysfunctional relationship with Khat. And what's important is this tells us that Khat is a big driver of their psychiatric illness. Maybe it is their psychiatric illness because it is so heavily weighted in our community in the mental health hospital. Almost more than half of people who chew chat use for the first time when they were less than 18 years old. The average age of first use was 17. Most people are chewing about 2.5 bundles per day, about $5 per day, or spending 7 hours per day. So imagine most people in the psychiatric hospital are spending, let's see, like $150 a month, 30 times $5, $150 per month on Khat, right? Like that's the entirety of their income if they have a job. Now look at almost the majority of the people in my hospital don't have a job. Um, 7 hours per day chewing chops, right? So that's like a full-time job. It's a full-time job of chewing chat, except all of the time is chewing chat and all of the money is being spent. A quarter of them have a family history of mental illness. 50% of them have a family history of addiction. And what's interesting is that there's no correlation between this DSM score and the amount of Khat use used, the time spent, the money spent, or the money spent. Um, so it seems to be more of an all or none phenomenon, or we don't have a large enough sample size yet. And what's important to note is that 92% are also smoking tobacco each day. So in Somaliland, the baseline demographic is that about 60% of people smoke tobacco each day. But among Khat users, 92% smoke tobacco each day. And going back to what we talked about before with tobacco, tobacco use is going to be a main driver of morbidity and mortality in this population. So again, this is going to be the most severe representation of Khat use in our community because this is sampling a population of people that have had to be admitted to the mental health hospital, usually for some kind of decompensated psychosis. But it's very important to see, even though we can't really go back and look at causation, right? Because we can't do a study where we assign people to chew chat every day for years and see how many of them develop psychosis. We can look at these numbers and say, wow, in among people who are experiencing psychiatric illness, there is a dramatic amount of Khat use, and that Khat use is having very severe comorbidities. It's having very severe effects on people's lives. So what this is telling us is that there's undoubtedly an effect of Khat use contributing and causing psychiatric illness in our community in Somaliland. And it's a huge burden. I mean, 87% of the guys in the hospital are chewing chat every day. And even think about the burden of this on a family. If you're unemployed and you're spending $150 a month and spending 7 hours a day chewing chat, that's going to drag down an entire family, an entire community. I mean, that's a salary, right? Um, and what's important about this research that I'm doing now in Gabile is 95% of those who I'm surveying have not had involvement in war or conflict. Okay. And this is what's important. This is different than the previous hot research that was done, is I've been able to sample a population that doesn't have this high overlap with PTSD and war trauma that makes it difficult to assess the psychiatric effect of pot use. We've been able to remove that variable from many of our patients. That doesn't mean that they haven't suffered from trauma or the traumas of life here in Somaliland or whatever abuses, and that they don't have PTSD. It's that we've been able to isolate this previously large confounding variable from much of the Khat literature. Here's a little bit more information about cotton tobacco, as we mentioned. So, like, for example, in Yemen, 27% of people altogether in Yemen smoke. But if you look at people who chew chat, 90% smoke. If you look at Somalia, this is going to be statistics from 2019, 20% of people smoke every day, but 75% of people who chew chat also smoke. So chat use is a mediator in a dramatic increase in tobacco use. And this is important for the country of Somaliland and for the region because that tobacco use is going to drive a large amount of morbidity and mortality. It's going to drive a lot of medical illness, strokes, heart attacks, cancers. That tobacco use is really going to be a burden on the community from a medical side. And so we need to be addressing not only the Khat use, but the tobacco use that comes along with it. Here's something that's really interesting that I'm the first person to sort of characterize well, and I have a publication in process about this that I'll love to share with you guys. This idea of dubab. I know many of you in the audience have probably heard of dubab. In Ethiopia, I did some research about this, also called dukak in the language there. And that's the idea of these nightmares that occur during Khat withdrawal. And so here's a very common story. Patients will tell you, okay, when I stopped chewing chat, within the first 1 to 3 nights, I have these vivid nightmares. And in these nightmares, there are snakes or there are lions, and they're chasing after me. And eventually they catch me and they swallow me. And I can't breathe because I'm in their stomach. Or They sit on my chest or they pile on top of me, or the snake wraps me up and I can't breathe and I feel like I'm being choked to death. I feel like I'm dying. It's a very common story. People will say it's a figure, either figure that comes to choke you when you stop chewing chop. Now, this has never been previously described in the medical literature, except for the publication that I have in process now. And what's interesting is 20% of the people who chew chat in the psychiatric hospital report having dubab with hospitalization. And of that 20%, about half of them say that this dubab is the main reason why they go back to chewing chat. They go back to chewing chat, they can't stop because the dubab, the nightmares, are so distressing and so problematic for them. Uh, and what's interesting is that this idea of dubab is exactly analogous to sleep paralysis. And what I believe dubab to be is actually just sleep paralysis. During sleep paralysis, what happens is REM sleep, rapid eye movement sleep, sort of emerges into consciousness. And in rapid eye movement sleep, your whole body is paralyzed except for your eyes so that you do not act out your dreams. And what happens is when you're in a state of whole body paralysis and it emerges into consciousness, it's very uncomfortable, especially if you're afraid and you're trying to get away from an evil figure in your dream. And what people notice is a feeling of being trapped, being unable to breathe, feeling paralyzed, and feeling like they're choking because they're having this autonomic arousal and trying to get away from some figure, but they can't catch their breath. They can't breathe faster than they need to because their body is paralyzed. This is a painting from the 1700s. It's called The Nightmare. And it's actually a depiction of sleep paralysis. Now, notice what we see in this. In this, the person is asleep. They can't move. And what's on their chest? There's something sitting on their chest so they can't breathe. And there's some kind of shadowy figure that's looking at them. When I have patients describe Dubab to me, they describe almost exactly this painting, this figure. So the practical thing about Khat withdrawal associated sleep paralysis, or Dubab, is that it is a huge driver. I mean, about half of 20% of patients, so maybe 10% of for 10% of patients that chew chat, Dubab is a main reason why they can't quit. So if we can figure out a way to prevent Dubab, we could potentially help these people recover from Khat addiction. Now, what's really interesting is each culture perceives psychiatric illness differently. So for men in Somaliland, they report, lions and snakes. Those are the cultural terms of something that you would fear. But, maybe in the 1700s, it's the exact same story, but they use a different depiction of some kind of demon or jinn, right? That's causing the sleep paralysis. So it's a unique representation of the intersection of culture and psychiatric illness. The other thing that's interesting is the majority of people also report using more tobacco in order to manage the dubab. And again, going back to the central importance of tobacco use, if we can manage the dubab, we can also decrease tobacco use among our people who use chop. So kind of wrapping up here before we can get to a time of discussion, what are the future directions? Like, what are some of the next steps in Khat addiction research in our community? And I think the first one is probably what's on everyone's mind, which is, well, what do we do? What are our behavioral or pharmacologic treatments for Khat use disorder? I'm in the process of establishing protocols for community-based support groups to help people recover from Khat addiction. And this is something that's very simple. All this looks like is getting people together who want to recover from Khat addiction who can hold each other accountable. This can be done with any kind of, formal program or informal, just creating the space for people to support each other from cot addiction. This has there's roots in ideas like Alcoholics Anonymous, AA, if you guys have ever heard about that. And there's even Islamic formulations of AA 12-step programs like Milati Islami that we're considering piloting in Somaliland. Uh, in addition, we hope to start open label trials of pharmacotherapy to manage the withdrawal and the cravings that come from COTS. This would have to happen slowly and over time, but it's possible that we could leverage some of the pharmacologic principles that we use to treat stimulant use disorder in the treatment of cot use disorder. Um, we really would be well served to understand, like, what is the burden of psychotic illness from chronic cot use in our community in Somaliland? How much of our psychotic illness that we see in the hospitals is a result of cot use, and how much is related to just the normal baseline level of psychiatric illness in the community? Now, this is really hard to do because we can't randomize people to chewing chat for 10 years and then see how many of them develop psychotic illnesses. We have ways of getting around that in epidemiologic studies, but it's very difficult in low resource locations to get good data over long periods of time that we could use to build some of these more advanced retrospective studies on cot use. So this is a big gap in the literature right now, and really it's only going to be filled by people like you in the audience who are willing to take on some large data collection projects and be willing to think outside the box for how we can start collecting more epidemiology in low resource environments like Somaliland. One thing that I've pioneered here in Gabile is actually the use of urine drug screens to detect cot use. So because cathinone, looks very similar to amphetamine, a standard urine drug screen, like an immunoassay, will detect cot. It will just show up as a positive for amphetamine. And I have done a case series that's confirmed this. And so what's helpful about this is that we can actually use this in the treatment of cot use disorder to provide some follow-up. And it also can be very helpful in the context of our psychiatric units to manage cases of undifferentiated psychosis by detecting cot use in people who wouldn't otherwise tell us or be able to tell us. And I think one last big future direction in the area of cot, especially in Somaliland, is what policies are needed to limit the negative effects of cot. Currently, we have a tax policy in place. It's sort of a work in progress because it hasn't done much to sort of pass on the cost to the end user, which is one of the main ways that taxation drives decreased consumption, is by making the substance more expensive and therefore less accessible. But one thing that is desperately needed is the establishment of minimum ages to prevent the development of cot use disorder. Going back to what we saw in Gabile and in a lot of other research, actually, is that the majority of people who really struggle with cot use, their first consistent use is in their teens. And as we know, time and again in the addiction literature, is that the earlier somebody is exposed to a substance, the higher risk they have for addiction in the future. So it should be something that we should really be actively exploring and having some public debate about, as far as the establishment of minimum ages around cot purchase and use.